Thank you. Thank you so much for having me today. So this is very much going to be focused sort of on symptom management, neurologic symptom management, since my colleagues are kind of speaking about things from the hepatic perspective and those medications. Neurologic symptoms in Wilson's disease, a neurologist's role might sort of come about one of two ways. We may end up seeing, a patient without a confirmed diagnosis of Wilson who has come to our attention because of neurologic symptoms. And so we might be involved in, the diagnostic workup, the pathway to diagnosis, or we may be seeing an individual with Wilson, who has a confirmed diagnosis. And again, our role is to assist with neurologic symptom management. So we know that copper, deposits in the brain. Specifically, it deposits in some of the deeper areas of the brain, such as the basal ganglia and the brainstem. So the basal ganglia is this group of structures that is very important for the regulation of movement. And so when there is dysfunction in the basal ganglia, people develop movement disorders. And really our definition of movement disorder is something that either makes somebody move too much, like abnormal involuntary movements, or something that causes someone to move too little. The complicated thing with Wilson is that it can mimic, symptoms of other movement disorders that we see a lot more commonly or frequently in the neurology clinic. Some of those things are Parkinson's, essential tremor, dystonia, ataxia. But an individual with Wilson may be showing kind of a combination of symptoms of these various different conditions and not be fitting the box for just one diagnosis. And that might actually be one of the things that leads us to, suspect or test for Wilson. So our workup generally is going to start with labs. We're usually going to be obtaining, blood work and urine studies, looking at copper, ceruloplasmin, liver function tests. Very frequently would order a brain MRI, and then also involve, other members of the interdisciplinary care team, an ophthalmologist to do a specialized eye exam for Kaiser-Fleischer rings, referral to our gastroenterology colleagues to help us with confirmation of diagnosis. This is just a quick example of an MRI of an individual with Wilson on the right and an unaffected individual on the left. And it's somewhat subtle, but basically what we're seeing on the right is symmetric T2 hyperintensities. That's our fancy way of saying abnormal brightness of the basal ganglia. And I might be able to, yeah. So this is part of the basal ganglia here, and then below are the thalami, which are other deep brain structures. So we're seeing abnormally bright signal there. Sometimes in Wilson we see the face of the giant panda sign on an MRI, which is abnormal signal within the midbrain, part of the brainstem, that kind of causes these structures to stand out that almost look like the eyes and the ears of a panda. So as far as this, subset of symptoms, movement disorder symptoms, the first I'll talk about is tremor. It can be present really in various different body regions, the face, the head, the limbs. If it's in the limbs, it's usually the type of tremor that happens with posture, so somebody holding a position, or with action. That's usually going to be the part that's noticeable to an individual because it may give them difficulty with their day-to-day activities, like writing, eating, drinking, fastening buttons. It can progress to what we refer to as a wing beating tremor, which is kind of if the arms are held in a certain posture, there can be this really large movement, which can be really severe in some cases. And we think tremor may be the most common neurological symptom that's encountered in Wilson. What do we do about it? We manage it in a very similar way to other tremor disorders. So I mentioned here first adaptive equipment. So that's kind of least risky, least potential side effects option, things like wrist weights or weighted utensils or adaptive pins. And so I often refer people, even who don't have a diagnosis of essential tremor, to the International Essential Tremor Foundation website, which is essentialtremor.org, because they have links to many of these items, adaptive items. We sometimes use medications. Probably the two most common are propranolol, which is a medicine often used to treat blood pressure or heart rate issues, and primidone, which is an older anti-seizure medication. We also can use botulinum toxin injections for tremor. So we could administer injections to the neck if somebody has a head tremor. We could administer injections to the arm. Potential downside of those is temporary weakness, but we try to be very, skilled and cautious with our injections in order to avoid that. And those injections do have to be repeated every 3 months because it wears off. Dystonia is another movement disorder we can encounter. So dystonia is involuntary muscle contraction that causes an abnormal posture or position of a particular part of the body. It can be focal, it can be in just one particular area or region, or it can be generalized where it involves many different body areas. It can be triggered by a certain action that somebody is trying to accomplish or a certain position of that part of the body. And so in that way, if somebody's attempting to speak and they have dystonia of their vocal cords or jaws, it could severely affect their speech. And another example would be somebody attempting to write and having maybe some abnormal spasm or contraction of their hand or wrist. And it may be the most disabling neurologic symptom that ends up being encountered in Wilson. So botulinum toxin injections really are our mainstay treatment in a lot of situations for dystonia. Again, those injections are administered they're targeted to the muscles or the muscle or muscles that we believe are involved in these abnormal contractions. So it is a targeted approach. We also, especially if the dystonia does affect multiple different body areas, we may need to use oral medications as well. Some of those are muscle relaxants, so things like baclofen. Trihexyphenidyl is kind of in its own group. It's what we call an anticholinergic medication. Children and very young people can often tolerate high doses of trihexyphenidyl, but you usually have to be pretty cautious in adults due to some of these side effects listed. Benzodiazepines, which are things like diazepam or clonazepam, do function as muscle relaxants as well. And in severe cases, so if we're not managing dystonia with medication or botulinum toxin, we might consider deep brain stimulation surgery. And that's a 2-phase neurosurgical procedure that involves implantation of electrodes within the brain, typically one on each side, and implantation of a pulse generator or battery that powers the device under the skin of the chest. And essentially the electrical pulses from DBS block some of the abnormal signaling within the brain. And for dystonia, the DBS electrodes do go within the basal ganglia that, those structures that I mentioned before that are really key to movement disorders. Parkinsonism is sort of another subset of symptoms. So those are symptoms resembling Parkinson's disease. It's not Parkinson's disease, but it shares some of the same maybe symptoms or features. So that can include reduced facial expression, slower, smaller movements, stiffness of the muscles, balance impairment, and a tremor that is opposite to the tremor we discussed earlier. So a Parkinsonian type tremor is one that's there at rest, when a person's arm or leg are just relaxed. Our treatment options, so we often do use, even when it's not Parkinson's disease, we kind of use the same medications to treat symptoms of Parkinsonism, even when it's caused by something else. So carbidopa-levodopa is a big mainstay medication for Parkinsonian symptoms. Because damage to the basal ganglia can affect the dopamine circuitry within the brain. The levodopa, which promotes dopamine, or is converted to dopamine essentially, can help to overcome some of that issue. We also rely a lot, on physical and occupational therapy to help improve mobility for people with Parkinsonism. I think ataxia is the last group I'm going to talk about. So ataxia essentially means balance or coordination problems. When ataxia affects the trunk or the torso, it can affect standing and walking balance, and it could lead to falls. When it affects the limbs, it can affect coordination, ability to reach for something or bring something to the mouth, or may cause somebody to overshoot a target. And it can also affect eye movements, the coordination of our eye movements, and the regulation of our speech, and cause a type of sort of slurred speech or impaired speech pattern. Treatment options. So we do not really have specific medications or specific procedures for ataxia. And so we do rely a lot on physical, occupational speech therapy to help people to compensate for those symptoms. Swallowing difficulty can kind of go under the umbrella of several of these different sort of movement disorder manifestations. People that, display Parkinsonism can have difficulty swallowing. People that have ataxia may as well. And complications, of that could be particles, bacteria going, into the airway, could possibly lead to pneumonia. And also we can run into issues with unintentional weight loss and the complications of that. So, we want to monitor and kind of keep an eye on those symptoms. We refer people to a speech language pathologist for a swallowing evaluation. Usually that's going to be a modified barium swallow or a fiber optic endoscopic evaluation of swallowing, and that may lead to speech swallow therapy. There also may be conversations if it's severe, and of course this depends on like an individual's wishes and their goals of care, but possibly conversations about alternative means of nutrition like a PEG tube. And then the last symptom is drooling. And that can be, a significantly bothersome symptom. And again, I go back to botulinum toxin. We use it for a lot of things in the neurology clinic, but botulinum toxin injections can be administered to the salivary glands. So in summary, neurologic symptoms are common in Wilson as the result of copper accumulation within the brain, and again, particularly within the basal ganglia. Sometimes neurological symptoms are the first sign of Wilson and may lead to the diagnosis. Neurologists can be an important part of interdisciplinary care. Most of the neurological symptoms are classified as movement disorders, things like tremor, dystonia, Parkinsonism, or ataxia. And we can use a combination of oral medication, botulinum toxin injection, and in severe cases, deep brain stimulation to help manage those symptoms. Thank you.